Hi, my name is Michelle Rensel, and I'm at the Salud Family Health Centers in Brighton. And my patient is BL, 53-year-old male, presenting to clinic today to review labs from previous visit and also to recheck rash that he had had on bilateral hands. Labs were reviewed and all were within normal ranges. They included a CMP, a hemoglobin A1C, and a lipid panel. During this visit, patient complained of muscle weakness and pain to the right leg and knee, lasting for an unspecified amount of time. Patient reports pain starts in the lower back on the right side and radiates down to the leg to the level of the knee. Patient also reports decreased activity tolerance as a result, and also activity as an aggravator. He reports similar pain to the right leg in the past, and that he has been told that his symptoms are secondary to prior right hip replacement. Patient currently is on indomethacin, but reports less adequate pain control than before for his gout. Denies redness or swelling in legs or joints, shortness of breath, crepitus, or muscle aching corresponding with the start of the statin, which he started last year. PMH includes hyperlipidemia, BPH, gout, for which he's on simvastatin, terazosin, and indomethacin. He also was put on triamcinolone cream for his rash on bilateral hands last visit. His physical exam was pretty unremarkable. His blood pressure, vitals were good. Blood pressure was 120/80, heart rate 76. Pain was at 3 or 4 out of 10, mostly achy weakness of the muscles. The exam revealed an alert, well-groomed, pleasant, Spanish-speaking man that is interacting appropriately. He seemed to be a reliable historian. He also was in no acute distress. His exam was for skin, was rash to bilateral hands, still unresolved. It seemed to be like dry, scaly, annular patches with irregular peeling and white edges on both palms. His musculoskeletal exam, he presented with full range of motion to right lower extremity, both extremities, but specifically right lower extremity. No edema or redness noted to any of his joints. Right leg was shorter than the other, which was after his hip surgery. He wears orthotic lift inserts for that. His right knee specifically, the joint was non-tender. No erythema, edema, or effusion. There was slight crepitus with movement, but no tenderness to palpation. McMurray's test was negative. Posterior, anterior drawer tests were all negative. The lateral and medial collateral ligaments were stable. No laxity in valgus or varus. We didn't perform any diagnostics this visit, but we were reviewing his labs from prior visit. His A1C was 5.9, so it was fine. His metabolic panel were all within normal limits. His, including his renal function, was fine. And liver functions were all normal. Lipid panel was actually in the optimal range, which puts him at low risk for coronary heart disease, according to the ATP3 guidelines. So my differential diagnosis was a gouty arthritis flare, leg and knee pain secondary to leg asymmetry, and knee pain secondary to statin use or a statin-induced myalgia, and then also dermatitis secondary to a fungal infection, contrary to what was previously thought. As far as his plan, because his lipid panel was optimal per the ATP3 guidelines, we instructed him to stop taking his simvastatin until follow-up in 4 weeks to see if the pain and weakness resolved. If pain does resolve, his hyperlipidemia persist, we will adjust the lipid-lowering medications accordingly until the lipid management goals are attained or maintained and the pain is resolved. If the pain is unresolved with discontinuation of the simvastatin, we were going to address other problems that could be causing his pain, including his gout, and possibly the need for physical therapy because of his leg asymmetry. For the patient's rash, we discontinued the prior triamcinolone steroid cream and prescribed the econazole nitrate cream 1%, one application to affected area daily. We instructed him to wash hands after use and to call if rash worsened And also we discussed common reactions like burning, itching, erythema. Follow-up was to be in 4 weeks. For his chronic conditions of gout and BPH, he was to continue his terazosin and his endomethacin for now, as previously prescribed. So my initial thought, my clinical question was, is it appropriate to discontinue the statin use in this patient who's complaining of muscle pain and weakness without assessing a serum CK or CPK level? So my articles, I kind of did a literature review because it was not as easy to find research on this as I had suspected. There weren't any new studies specifically addressing the monitoring parameters for myopathies with statin use. All the articles found pretty much referenced the ATP3 guidelines from 2001. Other research that I found that was more recent actually repeatedly referenced an article from 2002. This article is the one that I decided to critique because it was the most referenced article by Pasternak et al. The article served as a clinical advisory. It summarized guidelines for providers in the appropriate use of statins, including the contraindications and safety monitoring. The recommendation was to monitor CPK or CK levels at initiation of statin therapy and also with complaints of muscle weakness, aches, and fatigue. The recommendations for monitoring these levels are based on the recommendations of the ATP3 guidelines of 2001. So, needless to say, the generalizability of it is decreased. There's not a lot of new research. The strength of recommendation taxonomy system for evaluating level evidence says that expert panel evidence is at a C level at best. There's no real systematic approach to evaluating methods or results. It's pretty much just a summary of all the research that they went over. So even though it's a level C, expert opinion does often guide medical practices, but it doesn't always, like we saw, reflect high level of evidence, which leaves us medical professionals to use our clinical judgment and consider the best options for the individual patient. Incidentally, I did a little bit more research and I did find newer studies, 2011. They were all observational studies, and what they looked at was the CPK levels and if they really corresponded to muscle injury, and it actually suggested that there was very little correlation between muscle injury and CK levels, because there were patients that had muscle pain with no corresponding CK level increase, and then they did muscle biopsies and found out they actually did have muscle injury, but the CK level didn't indicate as such. For future encounters, I will probably continue to use clinical judgment, obviously, in regards to resources, because they may or may not provide valuable information for your individual patient. Our patient was in the optimal range for lipid screen and currently at low risk per ATP3, so I believe it was safe and appropriate to wait 4 weeks off of statin to reevaluate his lipids and pain before proceeding to maybe more costly, complex treatment. My theorist was Madeline Leninger, Culture, Care, Diversity, and Universality theory. It describes the need for culturally congruent care. It says if treatment is in direct conflict with cultural norms and values without negotiation or compromise, the likelihood of success is low. So when dealing with underserved communities, my patient was a CICP patient, no insurance. It's extremely important to take into consideration what they value. This ensures higher success rate of compliance and ultimately better outcomes. This particular patient had limited means and support systems, so our plan for him took this into consideration, and our best option was to keep it simple and cost efficient as possible, also while keeping our patient safe.